Hello, good afternoon, everyone. Welcome to this session on heterotopic tricuspid valves, to who, when, and how. My name is Victoria Delgado from Hospital Germans Trias i Pujol in Barcelona, and I have the pleasure to co-moderate the session with Dr. Sondos Samar Gandhi from Saudi Arabia. We have experts speaking about the selection of patients for heterotopic tricuspid valve, patients with tricuspid regurgitation. So if you want to identify the ideal candidates with severe tricuspid regurgitation that will benefit from this therapy, you are now in the right place. And also you will learn which are the key procedural factors to ensure that the procedure is successful and the patients will be happy at home and enjoying life. So I have the pleasure to have as a discussants Dr. Marta Sitges from Barcelona Hospital Clinic and Dr. Asmi bin Mod from Kuala Lumpur. Thank you for being with us. And we are looking forward for this session. If you have any comments or questions, there is one mic here. You just raise your hand. I can also bring you the mic, introduce yourself, and make your question. And without further ado, I would like my co-chair to introduce the first speaker.
Thank you, Dr. Delgado, for the nice introduction and laying out the session. So welcome to this interesting session today. We're going to start with our first speaker, Dr. Angel Sanchez Recalled. We're going to talk about the current evidence on the use of and the safety and efficacy of heterotopic tricuspid valves. The floor is yours, doctor.
Thank you so much. I'd like to thank the organizers for inviting me to participate in this very interesting symposium. And this is my conflict of interest. So TricValve system is the first CAVI implantation device with the CE mark, and it may be the only solution for patients with torrential or massive TR who are inoperable or poor candidates for tricuspid transcatheter orthotopic repair or replacement. Currently, the clinical evidence is very limited, and it's based on the TricValve EuroPCR study for the achievement of the CE mark, with only 35 patients. This study showed that there was an improvement in the functional class and also in the quality of life, as determined by the KCCQ, and similarly to, or even better, to other tricuspid transcatheter therapies. And this improvement was confirmed at 1 year of follow-up. And I will present for the first time the TricValve valve study. It's a multi-center registry initiated by investigators and not supported by any external funding. That included 204 patients from 26 European hospitals and a Brazilian center. These are the participating centers. Patients with right heart failure due to severe TR were not suitable for transcatheter repair replacement, and with suitable anatomy for TricValve. Patients with severe right or left heart dysfunction, severe pulmonary hypertension, and a big wave less than 50 millimeters of mercury were usually rejected for this therapy. So the patients in this series had a lot of comorbidities. It's remarkable, 50% of the patients had a previous cardiac valve surgery, and also 19% of the patients had been treated with transcatheter valve intervention previously. 34% of the patients had pacemaker, and very importantly, the TRI-score was very high, 23%. That means that the predicted hospital mortality in this series is 23%. 60% of the patients had at least one previous admission to the hospital, and the vast majority of the patients had a massive or torrential TR. So what about the safety of the procedure? These endpoints are defined following the tricuspid valve academic research consortium definition. So the interprocedural success was 96%. There were 7 patients with who required a second valve implantation. after the migration of the first one, the first one valve, the hospital mortality was 8%. The severe bleeding was 9%. And interestingly, there was 3 patients with cardiac tamponade, 4 patients with new pacemaker implantation, 1 patient with a lead dysfunction after the procedure, and the most common complication was shoulder pain in about half of the patients. The median length of hospital stay was 8 days, and the mean fluoroscopy time was 30 minutes. So CABI therapy improved significantly in the functional class of the patients. 81% of the patients were in class 1 or 2 after 1 year of follow-up, compared to 19% at baseline. And also the patients improved the peripheral edema and the ascites at 1 year of follow-up. And also very interesting that there was a dramatic reduction in heart failure hospitalization from 60% previous the therapy to 25% after the therapy at least 1 year of follow-up. And also there was a significant decrease in the dosage of the diuretic at 1 year of follow-up. ECHO showed that there was a transient worsening in the RV function that recovered within a year, and also there was a positive remodeling of the RV. What about the invasive measurements? So there were a significant decrease in the mean pressure in the inferior vena cava, and also in the big wave of the inferior vena cava at 3 months of follow-up. So after Kaplan-Meier survival analysis, the estimated total mortality at 1 year is 25%, and similarly the heart failure rehospitalization. So in this case, the incident rate of the events is very high at the very beginning, within the first 3 months, and after and over the time, the rate of events decreased a lot. And finally, the predictors all-cause mortality and heart failure hospitalization were to have previous hospitalization for heart failure, and also the hepatic and renal dysfunction. So to conclude, TricValve registry demonstrated that TricValve system is feasible and with an acceptable safety profile in this highly comorbid patient population and in an advanced stage of the disease. And the treatment with TricValve had a meaningful improvement in functional class, and also the venous peripheral congestion at 1 year of follow-up, and also with a significant reduction in the readmissions for right heart failure. And also the TricValve effectively reduced the IVC pressure and promotes a positive RV remodeling despite the presence of massive or torrential TR at baseline in the vast majority of the patients. And previous heart failure admissions, renal and hepatic dysfunction were the independent predictors of mortality and heart failure rehospitalization. Thank you so much.
Thank you so much, Angel. While the audience is thinking what questions, if you have, also remind you that you have the app that you can ask the questions. Maybe for our panel, what do you think about the results of this registry? Quite promising with such a high successful rate.
Yeah, I don't think it's quite surprising, I think, for us to see these results. I think for centers that has done procedures like this, I think it is quite relative straightforward procedure with less complications rate. And of course, I think in the majority of the cases that we have seen who underwent this actually improve symptomatically almost immediately. I think one of the things that we have seen from the center that I'm from in Kuala Lumpur, we have done up to 11 cases now, and majority of the cases I think there's improved symptomatically, and in fact I think you're able to reduce the diuretics almost immediately. But I think the idea of it is actually to try and maintain the diuretics to begin with, I think, before you cut down. So, not really surprising looking at the results. But indeed, I think it's great for us to see positive results like this to ensure, I think, to solidify in terms of what we understand with this.
So, Thank you, Dr. Sanchez-Recalde, for sharing this experience, which indeed is the largest that we have now reported. And I think, in agreement with what has been said before, is quite confirmation of what we have experienced. You think that this might be a futile therapy, but indeed, when you start to do this, you see a big change in these patients, even they are in a very advanced stage of the disease, no? And I think this is a very rapidly evolving field, and we are learning a lot. So in this sense, I mean, I was quite surprised. 70% of them had chronic renal insufficiency. I mean, that's a lot. And these are, we know, these are very sick patients. They do very badly whatever you do. So, I mean, this is really impressive. May I have some questions for him? Maybe to share with the audience, I mean, this is something that is frequent. I think it was 47% reported, shoulder pain. Can you elaborate a little bit on why do these patients have this? And anything that we can do to avoid, or should we worry it? How do we deal with it? How do we treat?
Yeah, it's a difficult question. I think the patients will be aware about this complication because it's frequent. The average duration is about 4 days. And I think it's good to treat. Maybe it's a good option to treat with gabapentin or other anti-inflammatory drugs before the procedure, to avoid, because it's painful and it's uncomfortable for the patient to have that. But the good thing that the duration is about a few days. But I think we can avoid it. The mechanism is the compression of the phrenic nerve, and it's impossible to avoid it with inferior vena cava prosthesis. So I think it's only to tell that to the family and the patient, and maybe to treat before the procedure.
So you mean to do prophylactic therapy,
Yeah.
you mean? Okay, that's your policy, no? Usually you do that in advance. Sorry.
Have more questions?
If you want, yes.
Yeah, I have another one question as well regarding the right ventricular function recovery, because for the echocardiographers or for the clinicians that do echo, when they refer patients for an intervention, they want to see the reduction of tricuspid regurgitation. But here, actually, what we want to know as well is how the right ventricle is doing. So do you have any data to share how this happened, and if that positive remodeling also reduced the regurgitation of the tricuspid valve?
Yeah, it's true. It's true. Firstly, the first experience with the RV reduction and RV positive remodeling is from Dr. Amat from Valladolid with CT scan with 22 patients. And with CT scan is the best imaging test to check the RV remodeling, and there was a RV remodeling, and also the right atrium didn't increase significantly, and also the registry confirmed that. So there was a positive remodeling, and also there was a significant reduction in the TR secondary to the RV. But the price is to have a transit worsening in the RV about 1 year.
Okay.
Great. We have a question from the audience. Like, we already tackled that those patients are very complex patients, and one of the predictor of outcomes is having multi-organ dysfunction, kidney, liver. So their question will be, shouldn't we be more aggressive with the indication in order to treat less sick patients, get them earlier? What do you think?
Yeah, I agree. We have to treat early as possible. So I think, the main concern is that we are treating patients in the end stage of the disease, and we have to avoid the futile procedure. So I think so. We have to treat in an early stage. We wait a lot, and in these cases, the mortality, the hospital mortality rate is for that reason. We are treating patients in advanced stage of the disease.
And as Dr. Mata mentioned, like 70 were having kidney problem, but yet only 5 from the registry required dialysis. So that's also a testament that it works. It will take some load from the kidney at the same time.
Are we?
Yeah. So we go to the next. Yeah. So thank you, doctor, for your great presentation. We move to the next talk. Dr. Michael Lee, please take the stage. So we're going to talk about how to identify the patient who will benefit. This is a continuation to the question that we just mentioned. So he will tell us how to select the best candidate for this treatment.
Well, thank you. Thank you for inviting me into this special TricValve session. These are my disclosures. We know tricuspid regurgitation is actually not a benign disease. Patients might have a lot of complaints, a lot of symptoms, palpitation, arrhythmias, aching, and then there are a lot of right heart symptoms, signs and symptoms as well, like edema, liver congestion, kidney overload. All these add up to actually, we should treat these tricuspid regurgitation patients more aggressively in an earlier stage. So for us to choose suitable patients to have TricValve procedure, there are certain criteria. First of all, clinically, the patient have to be symptomatic from tricuspid regurgitation with evidence of right heart failure. Patient usually will be in New York Heart Association class 3 and 4, despite optimal medical therapy. Right heart catheterization is highly recommended for all patients undergoing TricValve before the implantation with TricValve. So what we are looking at is a V-wave in both the IVC and the SVC have to be more than or equal to 15 millimeter mercury from the right heart cath. And then the systolic pulmonary pressure should be less than 65. And with the echo, we really have to have adequate right heart function with TAP-C more than 12. So usually we would choose patients with significant hemodynamic tricuspid regurgitation and relevant K4 reflux. There are, of course, certain anatomical requirements as well. We need to have a CT scan of the patient for all cases. So we measure both the SVC and IVC diameter at different levels, as well as the length between the confluence to the middle, the mid of PA, and then to RA for the SVC, as well as the length from the hepatic ring to the RA. So these are very meticulous measurements that we have to fulfill before we actually recommend TricValve for our patients. We know for tricuspid regurgitation, there might be primary and secondary, might be more with the secondary causes of tricuspid regurgitation. These are the recommended algorithm how we should treat our patients with tricuspid regurgitation, both for secondary and primary tricuspid regurgitation. But at the end of the day, you see that actually both primary and secondary TR can be treated by the TricValve. So we usually would choose frailer patients who might benefit from a softer approach instead of all those aggressive edge-to-edge repair or even putting in a tricuspid valve percutaneously. And then the main focus of the TricValve, as mentioned earlier, is mainly for symptom improvement and then quality of life. And at the end of the day, hopefully we can prolong their survival. So there are basically two main approaches. First, it can be the primary approach to treat tricuspid regurgitation if we can have a K4 reflux which is relevant, more than 15 mm mercury, or if we have previous intervention for tricuspid valve, no matter it is clipped or annuloplasty, we can actually reserve TricValve to be a rescue procedure when all these devices fail. You've seen this Tricus and Tricus Euro study. You have to bear in mind these are, as mentioned earlier, really, really sick patients. Majority of these patients are having atrial fibrillation, severe renal impairment, and liver impairment as well. And then there are previous valve surgery in a lot of these patients. So these are the real sick patients, but at the end of the day, we can achieve good results for this group of very sick patients. So I'm sure if we treat patients earlier, then we probably will have even better results. So in order to have this procedure done, we have to prepare the patient. So we just 1 or 2 days before the TricValve procedure, we need to probably increase the dose of diuretics, try to take out as much fluid as we can from the patients. We give antibiotic prophylaxis, and during the procedure, we maintained ACT more than 250. And then after the procedure, lifelong anticoagulation with either warfarin and DOAC is highly recommended. Shoulder pain has been mentioned as a result of phrenic nerve compression. Gabapentin or other neuropathic drugs might be suitable for these patients. And maybe sometimes we need to give the patients before the procedure just to prevent the shoulder pain. And then very dramatically, you will see that we can reduce the dose of diuretics very shortly after the procedure. There are certain contraindications which is not very different from other procedures. If the patient has a recent stroke or recent MI, we of course would not recommend this procedure to be done very early. If the patient is having hypersensitivity, allergy, or active sepsis, thrombosis, then these patients are not suitable. We need a transesophageal echo during the procedure, so if there's a contraindication to TEE, probably we should not recruit these patients. Patients with very poor renal function, we should actually think twice before we recruit these patients. And then if the patient are having bleeding, dialysis, active gastritis, ulcer, pregnancy, and so on, these are sort of the contraindications, which is, I think, is not very different from other procedures. So to give you a real life example, 80 years old female with rheumatic heart disease, she has been undergoing quite a number of procedures before. Pacemaker implantation, mechanical mitral prosthesis has been implanted, and then aortic valve prosthesis with tricuspid annuloplasty done, but still she returned with class 3 symptoms, ascites, and edema, requiring quite a number of hospitalization. Elevated BNP and with actually very poor ejection fraction. Echo show a severe TR with RV dilatation, but still the RV function was preserved. And then you see we performed right heart catheterization as well with a mean PA of 34 and a V wave in the SVC and IVC of 24, 25, and the pulmonary wedge pressure of 25. So these are the medications that we have put the patient on. If you look at the echo, there was dilatation of the RA and RV, and with severe TR because of the annular dilatation, and then the pacemaker lead was actually impinged on the posterior leaflet, causing a lot of tricuspid regurgitation. These are the measurements from CT, and then TAP-C show a satisfactory RV function. We managed to put in both SVC and IVC valve as shown here. Immediately you show the pressure and then the two valves in the SVC and IVC. This is what it looks in 3D TEE. And on subsequent follow-up, the patient's symptom actually improved dramatically. At 1 year follow-up, basically she returned to class 1 and 2 functional class, no further readmissions and no signs of right heart failure. BNP came down, and the dose of diuretics can actually be reduced significantly. So I think this is what we are hoping for by using TricValve to treat these sort of very indicated patients. We can bring patients from class 3, class 4 heart failure all the way to class 1, class 2, and then improve their symptoms of right heart failure quite a lot in the future. Thank you.
Thank you. Thank you, Dr. Lee, for the brilliant presentation. So I have a couple of questions and make it more relevant to your case. So we can see that you can see lots of prevalence of patients who had the previous cardiac surgery and multivalvular surgery, as in your case. So what is your approach in terms of like if there's an annuloplasty and you have, in addition to the tricuspid regurgitation, some element of stenosis with a gradient ranging between 4 and 5 maybe? That's the first question. And in the same case, you had an ICD lead. So how do you tackle this patient? And in terms of the preparation, do you consult EP? And do you have more aggressive approach afterward? So those are
like for TR with some gradient across, It also depends on the gap that we have to assess and see how feasible we are to use the edge-to-edge repair. I think for now, in our center, edge-to-edge repair is still the first line of treatment for severe TR patients. But a lot of time, this is not suitable. Either the gap is too wide or the gradient is too high. Then we have no doubt to switch to TricValve implantation right away. And then we will talk to our EP specialists about this pacemaker or ICD lead. But usually there will be no problem to just get the pacemaker lead or the ICD lead opposed to the wall, and then we check the threshold afterwards. Usually there's no effect on the pacemaker lead at all.
Okay, great.
Thank you very much for your presentation. I was quite surprised that in the list of contraindications you included transesophageal echo problems. Are you routinely guiding with transesophageal? Because most of the time, I mean, for us, we routinely guide with transthoracic echocardiography. So I don't know.
Okay, this is something we have to learn from you. For now, we still will perform TEE for all our patients.
Of course, angiographic guidance with
yes.
transthoracic.
Unless the patient is not suitable for TEE, some varices or gastritis, then sometimes we can think of the TTE together with angiogram support as well. Yes.
Dr. Lee, just asking about anticoagulation post-procedure. What would you handle this? Of course, majority of the cases that we've seen on the registry that they will have atrial fibrillation, isn't it? So in a way, they will end up with a long-term or lifelong anticoagulations. But what's your practice, for patients in sinus rhythm?
Yes, because this is valves in the low flow system on the right side, so I think we need to put the patient on some sort of anticoagulation. So we will put either the patient on warfarin still, maintain an INR, or we use NOAD sometimes. But I think for this sort of valve, still advisable to put the patient on anticoagulation lifelong until we have further evidence.
Great. Thank you, Dr. Lee, again.
Thank you.
Rounds of applause for Dr. Lee. So, moving to the next speaker, without any need for introduction, Safir Farisha, please.
Hi. Thank you for the invitation. And actually, I'm going to do something different because you're going to see a live case later. So we thought that the best way, just to show you tips and tricks, is to have a good knowledge of the system, of the valve, but also the anatomy. So I will try to draw, things, okay? So first of all, we're going to talk about the superior system, superior vena cava, okay? And you know that the valve, it's more or less like that. And it's really important to have the knowledge of the system. So this valve will have a skirt that will come more or less like from, like here, just half, and then it will go up to the limit, okay? That would be the skirt to avoid paravalvular leaks. And the other thing is that the system, the valve, is gonna be here. Okay, so we have two sizes, 25 and 29, and 25 and 29, it's always here, okay, at this level, and this is 10 millimeters more, this belly. We call this belly. Okay, so how we implant it in the system, in the cabin, superior system. So then, again, because there's a lot of confusion, I think that it's important to identify all the structures. So first of all, we have the jugular, then we have the subclavia, then we have the brachiocephalic, because then you'll see all the measurements. After, we have the innominate, that it's going to be important. And then, here, we have the azygos, that this can, like drive you to a lot of confusions, and some people, might confuse with the innominate. So that's the azygos, that usually in patients with TR, it's enlarged. So it can, drive to some, confusion. And then you have the superior, and then the right atrium. So what are the important measurements here? Because there's a lot of things, no, here. And before that, I will just change the color. sorry, here. And then you'll see that we have this. And this is a marker that we, in every case, we put a catheter in the right pulmonary artery. So why is that important? Why is that important, that marker? Because you will see that that will be, our marker when we're implanting the valve. This is just not so easy. Okay, so the important measurements, it's going to be, the most important measurement is going to be from here, to the confluence of the innominate in this pulmonary artery. And the magic number, it's 35. You need at least 35 because the belly needs to be or sit here. And the other magic number, it's here, it's a brachiocephalic, that it's 14 millimeters. Why you need 14 millimeters? Because in case that you're lacking space, you will have to go with the upper part into the brachiocephalic vein, and you need like some, diameter. So if it's very small, it's going to be dangerous. Okay, so just to go a little bit higher. How you implant the TricValve here? Because we measure, here, and then we oversize 5 millimeters, more or less, just to decide between one and the other. And how we implant? So we always put the belly over the pulmonary artery. So if we have enough space, it doesn't matter brachiocephalic vein. So the marker is, this is the pulmonary, so here. That's the belly, okay? So then the TricValve will go like this, belly, belly, and like this. And we always need to remember that, the skirt is going to be half of the belly. So in this case, the belly will be here in the middle, and there's no problem. But in cases that we need to go a little bit higher, so remember that the belly cannot go through, over the innominate. So in this case, it will be like this. And remember, belly always over the right pulmonary artery. I don't know if there is any questions.
Good that you ask, because there are many people taking pictures, so you have another
So sorry for this last,
picture.
It was going very well, and then at the end, this is a mess. But
and one question from me: do you do these measurements on the angio or on the CT?
MCT.
On CT, okay, and you
CT,
can get the same marker of the pulmonary artery and everything as nice as you have put.
Yeah, but exactly. But then, when you are just you're doing the case, that catheter is going to be very important, and you can make the measurement. So it's very easy, and I think that if you keep this in mind for the next case, you're going to be able to, just use all these markers and see how it works. So no more questions. We go to the inferior. Okay.
So before or while you are cleaning, you say that you cannot pass the innominate is because of anchoring or because of complications later on in terms, for example, of occluding the azygos with the skirt. What
well,
can you have?
The azygos, it's okay that we occlude it with the skirt. So that the fact that we don't want it's that it's not permeable. So we stop the flow. So I don't know what happened. Probably, the system, the body is super intelligent, will find, some collaterals, but you don't want to do this, at the beginning. And that happens when you don't have enough space. So you have to go up. Okay? So second, then change color. It's not so bad, so far. Okay, second valve, it's inferior, vena cava. So we have two. It's 31 and 35. Okay, and the system, it's like this. It's more conventional. It's like a little bit rounded like this and like this. And we have the skirt here and the upper part, and that's important. This data, it's important. The valve, it's going to open here. It's just at the top. And then the skirt, and this is important to know, 2.3 millimeters. That is very relevant. The measurement, the 31, 35, will be at this level, okay? So it will be more or less, because the valve, the inferior vena cava, opens a little bit, opens up, flares a little bit. So then, in the anatomy, we will have the tricuspid valve more or less here. And we will have the suprahepatic ostium. Not bad. So it's like that, where we measure to decide between one and the other, more or less at this level. So then we oversize, like in the superior, at least 5 millimeters. So if you have like a super enlarged, then that will be a limitation, but that's not common. What's the magic number here? This. Why is so important this? Because that needs to be at least 5 millimeters, because it's the tissue that will anchor the valve. If you don't have this tissue, the valve or will just the tendency will go into the right atrium or will go into the suprahepatic vein. And how we implant? We implant the valve. Let me change color. We implant the valve more or less like this. Remember that the valve is here and we have the skirt. The skirt, it's 2.3. What's the maximum distance that we can go in? It depends on that, but if we go more than 2.3, so it will be all in, so we will have to do it. So the recommended distance, it's maximum of 10, sometimes 50 millimeters, but I would say, 1 centimeter. 1 centimeter, it's enough.
Wait a moment, because I think that they need to reorient the camera because people from the online audience is not seeing your drawing and they cannot miss it.
Well, it's okay.
But if they don't see it, you can continue.
No, what I'm stopping, but that's important, and it's all about knowledge of the system. So if you know that there is 23 millimeters, 2.3, and you have this distance, you will know that if you go in, so there's going to be a leak here, and if you go too deep inside, you're going to occlude, like denominate, you're going to occlude the suprahepatic vein. So the objective, the target would be more or less this protrusion of 1 centimeter, and then it's fine. The valve flares a little bit, and you will see in the case. The superior, I would say that maybe you found it more complex because there are like different veins, but it's very easy to implant. This one, it's a little bit more tricky, and usually you need to pull back, because the valve will always have the tendency to go in, especially if this is short. So I think that with this, we're prepared for the live case.
I think so. It's a perfect pass to Dr. Nacho Amat, that he will show a case. But before you leave, just one question. Is it useful for you the tools such as the CT Navigator or tools that overlay the CT planning on the fluoroscopy for the guidance of the procedure?
Well, you were talking about renal insufficiency. You can do these cases with, contrast that is diluted. But if you have these markers and they're precise, I think you can even just do it with a very amount of contrast. So for those patients, I think that it can be very interesting.
Perfect.
Special tips and tricks how to prevent the jumping of
Well, yeah. It jumps, the excessive oversizing, it's not good, but it might happen, but it's always, just try to go. I would say the best trip, it's go slow, very slow, very, very slow. Because, like all of us, we sometimes tend to go fast, so slow.
So for me, it's a great pleasure to present the case after Dr. Fraser. It was very educative, thank you, Xavi. And these are my disclosures. So we are going to start by a standard case. It's not so standard because it's a male, so most of our patients have been women, but in this case we have a young male with a rheumatic valve disease. You can see in the echo that it's rheumatic, so it's not a good candidate for edge-to-edge. And it's a very large annuli, so it was also excluded for orthotopic valves. This is the selection of the case. He had a prior surgery on the mitral and aortic valves in 2000. And we perform a right heart catheterization with appropriate parameters, a very high right atrial pressure, which is very common and seen in these patients. And then we perform the CT, that has been very nicely explained. But the key is also to perform a good CT. So this has to be adapted to the filtration, to the weight, to the body surface of the patient. The acquisition of the images are at both times, in the very early phase for the superior vena cava, and then very late acquisition to see the inferior vena cava. The opacification of the inferior vena cava is led mainly by the regurgitant flow from the tricuspid. So it's also an indirect parameter of severity of the tricuspid regurgitation. If we don't see clearly the inferior vena cava, or we acquire very early or the severity maybe is not so important. Or there is a third reason, a very prominent Eustachian valve that can preclude the contrast from going to the inferior vena cava. Then we need something else to analyze it. And the CT can also help in analyzing the dimensions, but also changing the projection a little bit to the side where we implant. So these are the measurements of the patient that I'm going to present. It was all adequate for TricValve 25, and I will show how we measure, so you can correlate with what was shown by Dr. Fraser. First, we measure above the bifurcation with innominate. Then below the bifurcation with innominate, and we acquire the area. Then right above the pulmonary artery, that will be our crossing point to settle the stability of the device, of the belly. Then below the pulmonary artery in the infundibulum, the entrance into the right atrium. And finally, the length, that ideally from the innominate to the atrium should be more than 4 centimeters. And then in our patient, we measured the parameters of inferior vena cava. This was for a TricValve 41 millimeters, and we measure right in the transition between inferior vena cava and right atrium, a little bit lower before the ostium of the hepatic vein, and in our patient, this distance was very short, 6 millimeters. This is an issue for the stability during the implant, so we have to take this into consideration. Remember this when I show the case. Then we measure also below the ostium of the hepatic vein, because this is the landing zone for the device. And finally, the distance. So this is our case. We position the catheter in the pulmonary artery, but then we remove. We just keep this image filmed so we can have it as a reference. We don't have to keep it all the procedure. We measure the pressures again, just in case something changed from the baseline catheterization. We can use fusion, as you can see in the upper panel. That is very helpful to position the valve. And we have the pictel in the innominate. We just perform a small injection if we need, when we think that the valve is correctly positioned. We make sure we are in the upper part of the belly, the second third of the valve, and then we can remove the pictel and deploy the valve. Normally, not very quick, but we can do this procedure a little bit quicker than for the inferior vena cava. So I will advance a little bit. We give it time to be properly deployed, especially when we reach the final part of the deployment. This is important to try to release the hooks one by one. The video is a little bit accelerated, and I am also a little bit accelerated sometimes, so it should be very slow. We remove the delivery system, we recapture, and the second delivery system is exactly the same, so we advance it. We already are positioning the inferior vena cava. We start opening, but the patient is awake, is not intubated, and he breathed. And see, in this patient, we were a little bit too low. It's opening within the hepatic vein. So what do? We just recapture the system, we position a little bit higher, and we start again. When the distance is very short, this can happen, especially if the patient is breathing very heavily, because there is more movement. We have the pictel, as you can see, positioned in the hepatic vein. We just do small injections when we want to verify our position. So we inject here. By angio looks good, but at this point, we deploy a little bit more and check by transthoracic echo, subcostal view. And we see that we are very much to the limit. So the valve is almost in the hepatic vein, so we let it up a little bit, and we continue our deployment. So again, it's very important to do it very slowly. And in this valve, it's particularly important because as we deploy, we need to keep pulling the delivery system, pulling it down. So when we are doing the final release, we are pulling all the structures. If we release quickly, all the structures will move up, and the valve can also move up. So we have to keep pulling until the last anchor is going to be released, when we have to relax the delivery system so that there is not this elastic force towards the atrium. And here you will see how the last hook is released. Give it the time. And this is the actual speed to release it. Okay, it was very stable, no movement. We remove the delivery system and we check the result by two means. First, the hemodynamics. We do a pullback with the pictel and look at the pressures. We have abolished this large V wave. There is no V wave in the inferior vena cava. So functionally, it's okay. And then we check by echo that there is no any kind of leak, any kind of backflow. So we only see flow from the hepatics and the inferior vena cava towards the atrium. And this is my tip. I'm not finished yet. I'm going to show something very quick. I saw a standard case but sometimes we have no standard cases. So this is a patient with a failing annuloplasty, again, a bad case for edge-to-edge, a bad case for orthotopic valves, so very standard case. The problem is that it's a patient with a very severe renal failure after his surgery, which was in January 2023, and therefore we could not do the CT, the patient refused to receive contrast, so we use IVUS. This is going to be very quick. Intravascular IVUS can be very useful. This is intravascular IVUS in the superior vena cava. We see the longitudinal view is 76 millimeters long from the bifurcation with the subclavian. We measure 12 millimeters to the bifurcation with the innominate, 11 millimeters the bifurcation with the innominate, and from there to the atrium, 46 millimeters. We have selected our valve already. We just do the measurements at the same points as with the CT, and then we move to the inferior vena cava, and we can measure again. This is more difficult, but we can measure again at the same spots as we do with CT, and then we can add some measurements in subcostal view, which normally are very clear. This is the above the hepatic, below the hepatic, and the length. And once this is done, we just perform the same standard procedure, no injection for the superior vena cava. And same thing for the inferior vena cava, where we can do a very kind deployment, and you can see again the effectiveness with a bolus V wave towards the atrium and no leaking here. And now, yes, I have finished. Thank you very much.
Thank you very much, Nacho. This is really like a very advanced already with the IVUS. I had to see it again, probably. I will have to see it again to understand. But can I ask you which number case was this one? Just for you, you had so well established the procedure that you feel confident to use it already with this imaging. We don't need transesophageal echo, we do transthoracic, we can do the measurements with IVUS even.
Okay. So we have done several cases. I will ask my colleague Sara Blasco how many, 40-something cases. She was also involved in the case and in most of the cases. And I have proctored many cases also. So now it's a very simple procedure, really. I think we have to avoid the general anesthesia, the TE, always if it is possible. And that can lead to what we have found in the study, the lowest mortality in any transcatheter tricuspid procedure. So this is key, I think.
Very important indeed. And I think that this set the stage for the next talk. Thank you so much, Nacho, for bringing us this experience. And I will introduce Dr. Samar Gandhi. She will speak about current status of transcatheter tricuspid valve therapies, what will be the place for heterotopic tricuspid valve in the guidelines. So,
thank you, Dr. Delegado. So without any further ado, I'm going to start. Already we're going to take a chapter and we're going to put everything we learned in the last 45 minutes together. So who are the patients who should go and be selected? We already covered this slide. We need patients who have a symptomatic TR with a V wave and a reasonable pulmonary hypertension, less than 65, with a good RV and a reasonable LV. And we talked about this already, that the clinical and anatomical physiological factor will suggest what your mode of treatment, because whenever the symptomatic burden is low, this is when your patient have the highest response to the treatment. Whereas when we go to the very sick end-stage patient, the response to the therapy will be limited. Because what? This is because of the progression of the TR and right-sided failure. It's a vicious cycle. Like you just keep going and going and going until it's going to be too late. So we should break this cycle earlier, or even at very, very beginning of the situation. Unfortunately, the guidelines, either the North American guidelines or the European guidelines, doesn't tell you anything that is a class 1 unless there is something in the left side of the heart. Otherwise, you're in the 2B, 2BC, something like that. And maybe just like very gracefully you mentioned, transcatheter can be approached in specific centers. And that's also, again, if you know, they go with the charts, again, they mention severe primary, secondary TR. But that doesn't mean the tricuspid interest has evolved in the last few years, and now we have further classification. It's just not mere primary and secondary. We're talking about secondary going with atrial, ventricle, and even said cardiac implanted-related devices. So we have expanded the terminology and the classification of TR. So what do you want to see in the guidelines? Do you want to see this? We should involve the heart team because these are very complex patients. This is just like a hypothetical suggestion. Should we put the age in the case? And I'm putting a range of ages between 65 and 75, considering the risk. And instead of putting the standard Euroscore, STS score, we talk about the tri-score. And if the patient having high tri-score or high risk, we should involve the hemodynamics, as Dr. Lee mentioned, that right study is very encouraged in these cases. And then you might consider transcatheter approach. And what do we have? We have lots of variable cases, but as it was mentioned, TEER is dominating, and now bicaval came like, the life-saving. So when should we do this? As we mentioned, functional TR, it's not just a valvular disease, it's actually more than that. So look into it in a bit different way. Look at the reduction of healthcare costs with decrease in the ascetic tab that it has mentioned already in the registry, lesser physician office clinic visit, involvement and improve the quality of life and therefore in the workforce. Look at the mortality. The registry showed 1 year. The cases that we're mentioning now or the studies that has been published, all of it talk about improving the quality of life over a course of 1 year. What if we extend these trials up to 4 years? Maybe we will see some sort of mortality improvement. And what about the other specialties? Should we involve the electrophysiologist with us, considering earlier arrhythmia approach and treatment and not just go with rate control and go for rhythm control and maybe have TEE-guided lead approach in order to avoid any lead-related TR? Involve the nephrologist, the hepatologist, even the transplant system. Maybe we then can have stronger implantation of transcatheter approach in our guidelines. So how can we do that? It's not that simple. This is, again, we're looking at the future. We have to think out of the box. What if we brought the bicaval approach case and compare it to TEER? Who do you think is going to win when it comes to the quality of life and reduction of the symptoms? I challenge you, if you have seen a TEER case, that the ascitic disappear within a course of month. Usually they take a very long time, if not. But we have seen, and we have mentioned this in the registry, and by even the cases that presented, they have significant improve in the lower lymphedema and ascitic tapping. And even right ventricular remodeling after a few months. Can have the courage to do a sham control trial? Well, we have like a glimpse of that today. We can do cases without GA, without TEE, because you don't have the burden of the financial booking an OR, bringing all the team with you. Just have an interventionist with you in the room, TTE probe with you, and then you can do the case very simply and easy. And what about when Dr. Lee mentioned severe, symptomatic, class 3, class 4? What if we get these patients earlier on, actually, before they become very symptomatic, depending more on the echo finding of, starting to have the TR, going to stage 4 or 5, or RV or PA pressure being impacted, maybe. Or even maybe lower lymphedema. Should we take them and control them with early surgery versus control and follow them? Or a transcatheter approach. And then we can see, will we make a difference or not? There is multiple future aspects. Ongoing randomization trial comparing transcatheter approach with medical therapy are expected to improve our understanding because 5 years ago, we didn't know much about this. Now we're in a different planet. Better to understand of which patient will drive the most benefit from TR intervention, as well as optimal timing for the intervention. We covered that. We have to take the best timing for these patients. Prospective study investigating the role of transcatheter in high-risk subgroup of patients, including those with advanced pulmonary hypertension and RV dysfunction, which we didn't cover much basis on that, but that's another talk. And we have seen this. We are evolving. We're considering heterotopic transcatheter replacement in carcinoid, Epstein, and even in transplant. So it's a big playground, and everyone now is having a role in this. And if I can leave you with something, it will be this slide. Those patients are complex patients. Heart team decision is a very major role in these patients, and they are good until they're not good. So pick them at the right time. Choose the best therapy for them, whatever it is, the kind of the transcatheter or the surgical approach that you're deciding, but pick them at the right time before it's too late. And with that, I thank everyone.
Thank you very much, Sondos, for this look at the future with the guidelines and this overview. We have time for discussion, so if there is any question from the panel or from the audience.
Well, no, just a little bit to comment on the future exciting perspectives that you're putting. I mean, I think one of the lacking information we have mainly on this type of procedures also is durability, and what happens to this bioprosthesis in this position. But as I said before, I mean, the acute results are really, really promising. And this is something that needs to be incorporated in the future when we have more knowledge,
That's why we have to extend our Eden registries, our trials, not just 1 year or 60 days. We have to go further in time and see multiple factors, like what will happen after 5 years, for example.
Yeah.
Yeah, very good presentation. And I think one of the things that in a center where you have both TE, TER, and also bicaval, I think you do see that the symptoms relief is actually faster in the bicaval as opposed to the TER. I think that's something that we've experienced that, and of course we probably need a little bit more information. Why is that happening, isn't it? So of course the TER is fixing the actual problem itself. But of course in terms of are we remodeling how far and how advanced is going to happen, how fast is going to happen compared to bicaval. So
true.
So any other question from the audience? There were a couple of few questions that were left here. One of them is the coronary sinus pressure elevation. Is that an issue for the doers?
That's a recurrent question,
okay.
Which means people think a lot about these issues. But actually, there is an acute increase in pressures, but in the follow-up, these pressures decrease. So I have not seen any issue. Anyway, we are using reducer and other devices to increase the pressure to reduce ischemia, and nothing happens. So I don't think there is any kind of impact on that.
And you were alluding to the relief of symptoms in these patients that sometimes is even faster than, for example, when you do an H2H repair. Do you think that is because it's completeness of the elimination of the tricuspid regurgitation that doesn't lead to that replenishment or that full situation of the belly, and that we are assessing the symptoms of the patients initially with tricuspid regurgitation wrongly? We are looking for the shortness of breath, and then we should search for other symptoms.
So dyspnea is a late symptom in these patients. So as Sondos said, we should not arrive late. If we wait for dyspnea, which was mostly evaluated by Triluminate and other trials, we have a wrong target, I think. Dyspnea is important. If it's there, we have to go for that. But we have to act in symptomatic patients with the 4 A's classification that the colleagues from Ramon y Cajal described, the ascites, the edema, other symptoms that I think are more important in these patients.
One question from the audience, please.
It's a great session. I have a quick question. So we all know that the volume status could affect the caval size. So how to deal with this issue? Thank you.
So in terms of like the pre-screening or after the case?
Pre-screening.
So, yeah.
The volume status.
So I think from my perspective, what at least our practice, we try to make the patient as much as possible euvolemic, or what's the usual status of the patient at home most of the time, like not during admission. And then we do the CT screening and we go with the sizes, because as it was mentioned already, we already oversize with a certain percentage. So you don't go like 1-to-1. So you have like a kind of safe net in the background. And usually as you go forward in time, the requirement for diuretics, as we mentioned, we don't just stop it the first day. We just go very gradually to give the heart and the vessels some time to accommodate. Ignacio, what do you think?
Yeah, so I think it's important to reassess the dimensions as the pressures also. There might be a decompensation from the time you consider baseline to the day of the procedure. So these things are important. This is why we still do some angios to make sure the cava. We have one case that from the CT was okay, and the day of the procedure was not okay. And that, we didn't implant because it was already for a 41, so it was too large. So we thought, okay, let's optimize. The CT was old 6 months ago. So I think we need to make sure imaging is updated.
That's what I heard, like if it is more than 6 months relapse, so you have to repeat it. Is that correct?
Ideally. Or IVUS.
I have a question to all of you. I don't know who will answer. How this technology will be positioned against the valve implantation in tricuspid position?
That's a very good question, and we try to address this with the guy list with Sondor. So perhaps you can.
So your question, like, if you put a bicaval valve, and now you, in the future, you want to put a second tricuspid valve, or before, or
who
compare?
Are the patients in whom you put it in vena cava against? Now you know it. There are valves which are being put in tricuspid position, orthotopic. What will be the place for this technology?
Well, at this stage, having a transcatheter valve replacement tricuspid is not very available across the Europe or in the Middle East or in North America. So at this stage now, still bicaval has a very major role because it's the available treatment, number one. Number two, for those patients, the screening is a bit tough. It's not that easy because we know that maybe 50% failure rates in some of the cases. For example, what is CE marked recently, the Evoke still. So even those patients, they're not as easy as you can get. Last point is about the RV mismatch after the implanting the valve. So some patients, they cannot tolerate implanting a valve, but maybe they can tolerate a bicaval valve. So it's still not there. You have to have a clinical sense of where you're going to go, have a heart team discussion, and have a very good MRI and right heart cath analysis. So you can know, an echocardiographer, of course, because he can tell you the TAPSE, the PA pressure, the coupling, everything. So you can have your best decision for your best patient. And then your screening, of course.
Well, this was kind of the last remark for ending this session, which has been outstanding. I would like to thank Products and Futures for sponsoring this session. I would like to thank the discussants and the presenters for the excellent presentations and discussions, and all the audience for this session. We will continue with more discussions, but I think we need another session. Thank you so much.